His name is Dr. Harith Akram. He takes a map of your brain and uses it to guide a surgical instrument within millimeters of a target that can change the course of your life.
The minute they hit that right spot in the brain, the tremor stopped, which was very moving. And then the patient started crying, and then I started crying. And I still do, actually. Every time that happens, I feel very emotional. It's a great thing to be able to do. The roads are there, the roads are not damaged, but the problem is in the traffic light system. And there's a traffic jam because of this. And that's why you're not, Parkinson's disease patient is not moving. All of a sudden, we've cleared the traffic, we've created another pathway. That's what we can learn and understand from studying these brain networks. I don't want people to suffer. If I can alleviate suffering in any way and make people's lives better, then that will make me very, very happy.
Welcome back to the Parkinson Performance Center podcast. If you have been here before, you know what this space is about. Science that doesn't condescend, conversation that don't oversimplify, and guests who bring both the depth of real expertise and the generosity to share it in a way that actually reaches you. Today's guest does something that, when you first hear it described, sounds almost like science fiction. He takes a map of your brain, the full integrated web of connection between regions and pathways and circuits and neurons, and uses it to guide a surgical instrument within millimeters of a target that can change the course of your life. His name is Dr. Harith Akram. He's a consultant neurosurgeon at the National Hospital for Neurology and Neurosurgery at the Queen Square in London, one of the most prestigious addresses in the world of neurology and neurosurgery, and honorary associate professor at the UCL London. He trained at the London School of Surgery, won the Norman Dodt Gold Medal for the highest mark in the Fellowship of the Royal College of Surgeons, surgical exam, earned a prestigious fellowship at the Barrow Neurological Institute in Arizona, and built his PhD, prize-winning as well, around the question that still drives everything he does. How can we use the brain's own connectivity to make neurosurgery more precise, more personal, and more effective? And his specialty is functional neurosurgery, deep brain stimulation for Parkinson, dystonia, essential tremor, but also OCD, Tourette syndrome, depression, cluster headache. He's a board member of the World Society of Stereotactic and Functional Neurosurgery, its newsletter editor-in-chief, and a keynote voice at conferences around the world. He also built something extraordinary, because some problems are too big for ordinary machines. The name of this thing, it's Gilgamesh. I just don't want to spoil too many things now for you. We will hear it directly from Dr. Harith Akram, okay? But how I would like to introduce him is something that I find even more special, even more remarkable. Whenever you read about him or you hear about people who were treated by Dr. Harith Akram, none of this technical brilliance seems to come at the cost of the human being sitting across from him. Patients describe him as kind, clear, present, someone inspirational, and someone who takes the time. And that combination, scientific rigor on one hand and genuine care on the other, is precisely what this podcast exists to bring into the room. We have many topics to cover, and so with no further ado, Dr. Harith Akram, welcome. It's a real privilege to have you here, and from the bottom of my heart, thank you for making the time.
Well, Guy, I mean, thank you. It's my pleasure, really, to be here, and thank you for this really kind introduction. It was very nice to receive your invitation to be with you on this podcast.
Thank you so much. Let's start to tell a little bit more about you to our listeners. I would like to start with your journey, with your story. So very simply, what drew you towards functional neurosurgery and specifically towards the brain's role in movement and behavior?
I mean, it was never an active decision to to end up doing basically what I'm doing now. But when it's something that was in me from when I was a child, and in my formative years, I was someone who is really interested in how things work, and my passion was taking things apart and trying to put them back together just to understand what's inside and how it works. And I was, from a younger age, interested in computers and building computers, and building circuits and taking circuit boards apart, and understanding how circuits work. And somehow that kind of led me to, when I was a medical student, I was just I was captivated by neurological disease and neurological system and diagnosis, because most of the times that involves the understanding of how brain circuits work and guessing what the pathology is. I mean, now we have very advanced imaging techniques and a lot of investigations that patients usually get even before seeing a doctor. But when I was training, it was all about your imagination and thinking about the symptoms, putting them all together, and then thinking about the anatomy, thinking about the circuit, and then saying, I know exactly where this problem is in the brain, and then you get a scan to show you exactly where you are. So that's really what drew me to neurology at first. But then that passion in me to do things with my hand drew me to neurosurgery, because then I can put the two together. I can do neurology, work with neurologists and understand diseases of the nervous system, but also have the tools to make a change by intervening on the brain itself and having access to the brain, which is a great privilege.
Well, that's also such a nice story. And would you then say that you still find the inspiration to drive your work and your research in the same passions and drive that you had since you were a child, basically? Or are there nowadays new source of inspirations?
No, absolutely. That is it. I mean, I don't consider what I do work. I mean, I'm one of those very lucky people who actually um, gets to do what he really loves, and I just really love doing this. It's and incredibly satisfying when you can help another human being, when you can turn pain off, or you can get someone to start moving again and living their lives, and enjoying their lives, and very, very satisfying, whilst actually doing something that I love anyway, and learning about things and then teaching others to do the same. Yes, I'm very, very lucky. You do something very similar, Gaia. I mean, you're equally passionate about helping patients with Parkinson's disease, and I've seen, I mean, I follow you closely, and I've seen the work that you do, and that must be very satisfying and very fulfilling for you.
It is. And I resonate fully also with what you say, that we are very lucky to have found a passion and be able to really follow it through and through. Definitely, it's like a privilege. And tell me, is there then maybe a patient story or a moment in your career, maybe also from the operating theater, that still stays with you and, as I have left a major impact on you and how you still operate?
Gosh, where do I start? There's so many patient stories that I have. I've been practicing for a while, so I have quite a few. But I think the first time I saw a patient who was having surgery for Parkinson's tremor. And that's before getting into functional neurosurgery. I was a very junior trainee, and I was visiting the Department of Functional Neurosurgery at Queen Square, and I met one of the best people in the world and greatest mentors that anyone can have, Professor Marwan Harith, and his young prodigy, Professor Ludwig Zrinzer, who then became my mentor and my supervisor. And they were doing an operation, and the patient was on the operating table awake with very disabling tremor. And the minute they hit that right spot in the brain, the tremor stopped, which was very moving, because it's a striking thing to see that you can, by doing something, so seemingly simple, you can kind of change someone's life in that way. And then the patient started crying, and then I started crying, and I still do actually. Every time that happens, I feel very emotional, because it's a great thing to be able to do. With neurosurgery is a specialty where most of the times we're trying to stop people from dying. We're trying to stop people from getting worse. Sometimes we succeed and sometimes we don't. But it's very rare that we make someone better. We do in lots of different ways, but most of the times it's kind of quite, we're fighting fire with fire and trying to stop disability or death. And to get patients to come into hospital in one state and leave the hospital much better than when they came in is great. It's just great to see and to be a part of. And then they write you letters and they write cards, and which kind of gives you the boost to keep going and keep trying to make it better.
Yeah, definitely. Well, my challenges are not as yours for sure, but when you hear people saying that you changed their life and that they will be forever grateful, it's, teaching them a new way of even living or doing things, it's just priceless. That's fully resonate. Let's push now a little bit more into your niche of expertise. And so I would like to understand more about the brain networks and translational neuroscience, because you work at the intersection of surgery and then what's called translational neuroscience. So for our listeners, what does that actually mean? And why does this matter for patients?
Yeah. I mean, that's we have, as neurosurgeons, as a functional neurosurgeon, I have this great opportunity of accessing the best resource that we have in science, which is the human being, the human brain. So we are in a way, rather than, there's very clever work that happens in basic science and in the labs, and that's really important. And you have surgeons on the other end, operating on patients and applying all this new knowledge. But what's missing in the middle, that's the valley of death, as it has been described before, is that bridge, that translation. Someone who can take these ideas from the lab, and these theoretical ideas, and then apply them to experiments and studies and imaging studies and neurophysiological studies, that will then be used in patient care. Most of the times it happens organically, that we can get scans and get imaging to map out networks in the brain. We then correlate these findings with outcomes from patients, because the patients are undergoing procedures like deep brain stimulation procedures or ablative procedures, and by doing these correlations, testing, generating hypotheses and testing these hypotheses, we can then go back and change the way we operate on patients or change the way we select patients, understand how the treatment works better. Because sometimes these treatments, I know this sounds crazy, but they actually came by accident, most of them. So they didn't come from science. We started operating. This is, I'll go back to the early 1900s when surgeons were operating on the brain to stop tremor. We didn't do that because of imaging or physiological studies. No, we did that because patients with tremor who also had strokes found that their tremor improved. And then when they died, we looked at their brains and we found, that stroke affected the motor cortex. Therefore, if we go and remove part of the motor cortex, we can get rid of the tremor. So it was observational, another, we discovered the role of the basal ganglia, these, neuronal structures at the base of the brain, and that we now target all the time with surgery for Parkinson's disease and other movement disorders. We discovered their role because some surgeon, Irving Cooper, very brilliant American neurosurgeon, was doing an operation to make someone weak to get rid of tremor. And during the operation, he injured an artery called the anterior choroidal artery, a very small blood vessel that supplies the basal ganglia. And he abandoned the operation because, he realized that he'd caused a stroke. But the patient woke up and the patient had improvement in tremor, also improvement in the slowness and the stiffness that comes with Parkinson's disease, rigidity and bradykinesia, but without having weakness. So actually, it was complete accident, a serendipity. We know that, okay, well, we're going to have to start doing this operation again from now on. But that didn't come from basic science. It came from accident, and it came from observation, from seeing patients. And our job now is to try to explain why these things work, try to refine, try to discover new areas in the brain to target. So yeah, you'll be surprised to know that a lot of surgical targets and procedures we know and we've developed, not because we had the science, but just because we saw that something worked and we kept doing it and trying to improve it.
Well, that's, it's funny. It makes me think of, well, on one side, the fun part, playful part of doing science in this way, but it's all trial and error. Sometimes we think, we always want to base everything on science because this is rigorous, it's, data driven. But then sometimes, when you realize that science is like really, okay, we have a question we want to investigate. Let's try to understand what is the best method. And literally just by trial and error, it's makes you more humble, at least like in my perspective, when I was also a young neuroscientist.
And I think in my field and in science in general, I think the greatest the great sentence you can say or think of is not, it's not eureka, it's, that's funny. Whenever something happens and you think, that's funny, I didn't expect that to happen. Why did that happen? And then, can I do that again? And that's really how we discover new things in my field sometimes, not always, but which is why it's really important to have a very attentive eye and to pay attention to these funny things that can happen around when you're doing your job.
And how would you say you do this? How do you train your eye to be sensitive to notice these details or these surprises that can happen?
Yeah, it's well, I think first of all, you need to be very thorough and systematic in what you do, and then you expect certain outcomes, and to be able to identify something unusual, you have to be very consistent in what you do, because If your results are random because your technique is random and you're not consistent with your decisions, for example, then it's very difficult to detect an anomaly, let's say. So that's one way of doing it. Functional neurosurgeons are known for being on the OCB spectrum. We are very, very meticulous at what we do. We love doing things exactly the same way because that's how we've always done them. So when you find something unusual, you really notice it.
Well, that's very, for me, just fascinating because like looking at the brain of a neurosurgeon would be like, wow, what's inside? You are a leading expert of something that we also call connectomics. So for our audience, let's just explain what is this field of research and how it is shaping the advancement of science nowadays.
Now I'm gonna just a word of caution before I delve into this, because the brain is often portrayed as this computer or this kind of device with lots of interconnected circuits, and that is to an extent a correct, kind of to an extent correct, but we still don't understand fully how parts of the brain integrate with each other, and we know that on a structural level there are a lot of connections, but there are connections that are functional. So there are some parts of the brain that are connected to other parts of the brain simply by having the scaffolding presence. So you can have those axons that are very long. They all kind of connect different parts so that there is, different areas can speak to each other. But also you can get areas that fire together at the same time in the brain. So if we put a patient in something called an MRI scan to get a functional MRI scan, you can see activation in parts of the brain that are seemingly not directly connected. So they might be on different parts of the brain, but they will light up at the same time. So these are called, these are functionally connected areas, whereas the directly connected areas are structurally connected areas. And the field of connectomics tries to study these circuits on the macro level. So what big regions are connected to each other and how they talk to each other and how they fire together, but also on a micro level, how there are some regions in the cortex are they connect to other regions in the cortex, and how the disease can change these. So far, that's what we've been focusing on. Now we're very bad at detecting the temporal connections. So we can see the connections, the spatial connections, but we don't know how these areas particularly talk to each other over time, or what's the flow of information is. I mean, we have a basic idea what the flow of information is through these, but it's possible that the brain has different frequencies, and it's like trying to listen to 200 radio stations at the same time, and to decipher. So there'll be different receivers getting different information. And my interest is now turning into how these connections correlate with genes in the brain. So we all have genes in our cells, and they have the main architecture, the blueprint, and that blueprint is present everywhere. In a skin cell, you'll have the same blueprint that you get in a nerve cell, except that the switches on these genes are different depending on where you are in the brain. So the card that opens the door to a certain protein is present in some cells, but not other cells. That's called epigenetics. We also know that there are mutations that can happen in some of these genes that we don't get in somatic cells, for example, in skin cells. And my interest now is how do we make this fit with the connectivity? So how do these genetic switches affect the way the brain, different parts of the brain talk to each other? So yeah, but to kind of go back to the beginning, it is sort of like a a computer circuit, but the level of complexity and the fact that it's something that is changing all the time, not a static map, makes it very exciting to study.
Yeah. Well, it's super inspirational what you just said also about the connection between these specific circuits and then how they, let's say, correlates to the expression of or mutation of few genes. Is the ultimate goal to understand also if, let's say, few people with PD who have like the gene, let's say, actually cause mainly, like not of course mostly environmental, but purely again looking at the gene side. Does this mean that they might have a very specific, say, network connectivity? And so would this eventually lead us to better treatment or helping them in, say, just the therapy?
Yes, yeah, that's absolutely it. So we now treat all Parkinson's disease the same way, which is crazy. I'm talking from the surgical, even medically. I mean, there are variations, but more or less try to fit everyone in the same box. And we know that Parkinson's disease is so variable. I mean, you don't have two patients with the same disease. It's a set of symptoms affects patients very differently, and we know that part of that variability is to do with the genetics. Part of it is to do with the wiring in the brain connectivity, and that's what we're trying to understand. Because ultimately, what we want to do is we want to stop Parkinson's disease, right? We want to cure it. This is for me, it's personal because my grandmother had Parkinson's disease. She had brain surgery for Parkinson's disease in Queen Square, where I work now. So yeah, so for me, it's personal. It's affected my family, and I can see every day how this disease affects people. It's horrible, I mean, I don't, obviously a lot of patients that do really well, and it doesn't affect them as much, but it it can really rob you of your life, especially, and it's affects people when they're just about to retire, or sometimes affects people much younger as well. And yes, what we want is eventually we want to get rid of it altogether. We don't see anyone with Parkinson's disease, and that will put me out of a job, but that's fine. I'll be happy. I can maybe learn how to draw or do something productive with myself. um, and what I want to do now is to give patients tailored therapy so that we know exactly who's going to respond to what. We know whether so it might be that someone will need to go and have a genetic therapy, someone who should only have medications, and someone who, no, actually this patient will do really well with deep brain stimulation. Let's do that, but then we will know exactly where in the brain, and we'll know exactly what parameters to use to program these patients, and these will be tailored to each patient. We know who's going to do well from exercise. We need to be able to treat the non-motor symptoms of Parkinson's disease, which we are very bad at treating. Apathy, cognitive problems, mood, all sorts of other conditions that we get with Parkinson's disease that we're really bad at treating right now. Speech problems, and we will get there if we better understand the disease. We need to know what we're fighting against, and then understand how our therapies work, and that will lead to better therapies.
Realistically, what do you think? How far from this scenario are we? Because, well, I also work daily with my participants, and I coach people that are in their 30s and 40s living with PD, and people in their 60s and 70s. So massive difference. Yet, of course, everybody have the same question. And I not to be, pessimistic, I'm just like more realistic, like I don't see the cure coming very soon. But importantly, linked to what you just taught us, so this idea of precision medicine, like really precision medicine, of really being able to treat every single individual as they need based on their characteristic. Are we really there? Or what do we need to do extra to be there?
Well, I think in the last 5 years, we've seen massive acceleration in development in this area. So I think we're getting there. I'm hoping that, within the next 5 years, this will be standard. I'll be really sad if in 15 years' time I'm still doing the same, implanting people with DBS electrodes and then doing trials of stimulation to see what's the best response we can get. I doubt very much that that's what we will be doing. I think we will be getting a lot more biomarkers and feedback from wearables, from the brain itself, to guide these therapies, to make them a lot more accurate. And we're getting there. I'm an optimist. If you're a pessimist, I'm an optimist. Although a friend always says to me that at the end, pessimists are usually right. but you need optimists in this world, otherwise nothing will ever happen.
So that's true.
I'm happy to be disappointed, but I'll still be optimistic.
Yeah, in my core, I would always say I'm incurable optimistic, but then when I do science, the rigor taught me to be, a little bit more not pessimistic, realistic. So
realist, pragmatic.
Yeah, pragmatic is correct. This is more like a personal curiosity. Do you think AI can help us in, let's say, getting there faster, or just accelerating a little bit, the discovery of some biomarkers or analysis, treatment?
My goodness, yes, absolutely. I mean, AI is going to. It's already changed our world. As an optimist, I think we have an incredible opportunity to discover new things. We just look at DeepMind's protein unfolding. That would have taken, I don't know how many years to do that. They manage. It's amazing, and I think science is just catching up with what we can do with these models. Most people, when they think about AI, they just think about making funny photos and writing emails, but it's I do a lot of coding, and I use AI assistants to write code, and what used to take me 6 months to do now takes me a couple of hours.
Amazing.
So you can imagine, AI is not going to have an idea for me. That's not going to happen. But now I can use my time in a way where I will never have time to sit down and write a new software to analyze the connectivity of the brain. Now I can just have the idea. I can tell it what functions to write. I give it a few minutes, and then there it is. So if we are innovative and use these models the right way, I think we can change the world. There's no question about that. Obviously, there are a lot of other caveats. The environmental impact of AI. That's something that we really need to look into and not contribute more to the environmental disasters and change that we are causing. Inequality, there's a huge potential that AI can make inequality even worse, with the tech companies that own these models, having, taking basically the jobs of millions or billions of human beings, and people with access will get all the resources, and that's something that we need to be responsible for. And also governance. We can't have AI agents making decisions that affects human beings without us being in charge. For example, I'm talking about war. I I don't condone any war. The use of these systems to guide weapons and whatnot is incredibly dangerous, I think. So, I think I'm digressing now, but just going back to neuroscience, we I don't now, if I get a PhD student and they can't code, or they can't use these AI models, I would not be I'm not taking them on, because I think they'll have a disability. Yeah. So it's becoming very important.
Yeah, I imagine that like in the future we will need to even make part of a medical degree, even like entire courses in specific AI and how to use it applied to even certain condition or like fields. It made me think though back when you said, the specificity of a neurosurgeon to be able to see the details and like really learn, like teach your eye. Well, similar to AI, it's the have the sensitivity to pose the correct question, the correct prompts, because otherwise AI will not give us those aha moments. Aha moments will come from our expertise and experience and years of doing and, also mistaking and again and try. And then AI can, potentially pinpoint even better the blind spot.
Yeah.
Coming back to one of your expertises, and more specifically to a landmark study that you published in Nature, mapping dysfunctional circuits in the frontal cortex using deep brain stimulation. Can you tell us a little bit more just what that research revealed and what does it mean for how we understand and even treat conditions like Parkinson's?
Yeah, I mean that's work I've been involved with led by Andy Horn, who's a genius, very very good friend of mine, and he's really one of the leading figures in the field of connectomics. And it's basically builds on work that him and I did in the past, where we looked at the circuits that are involved with deep brain stimulation. We both published work on finding sweet spots in target nuclei, like in the subthalamic nucleus, work I did in about 10 years ago, I think, and how these circuits are affected by what's called the hyperdirect pathway. So a direct connection from the cortex and to the nucleus. And what we did with Andy and his brilliant team did was to map out these connections, but in different symptoms rather than. So maybe let me take a step back. What we're doing with modulating the brain with DBS leads and with electrodes is that we're not targeting a disease. Right? The disease is what's affecting the cells and what's affecting the networks. We're targeting the symptoms. So the disease can cause a dysfunction in a certain network, let's say the tremor network. And what the patients get is tremor. So when we try to modulate a network, we are targeting the tremor. We want to get rid of the tremor. We want to get rid of the rigidity. We want to get rid of the bradykinesia or OCD. We want to get rid of obsessive thoughts or compulsion, or anxiety in depression. And what we did was basically try to map out how each one of those spots that can alleviate these symptoms is connected to a different part of the brain. And it's something, it's, when you think about it, it's quite intuitive. You'd think that you'd find that, but to a level of granularity that we've not seen before. And we can see how the frontal cortex is implicated in mental health and in movement disorders. And interestingly, after that work was published, so more recently, we've learned more about how connections to frontal networks, especially what's now called the or people call it a action mode network, which is the singular opercular network. So it's a cognitive hub in the brain that drives movement, and that's something that's really important in Parkinson's disease, because we used to think that Parkinson's disease is a dysfunction of what's called the effector parts of the motor cortex. So you think, right, your hand is slow is because the hand area in the motor cortex is not working, because it's been influenced by increased output from the basal ganglia that's put the brakes on the hand area. Now we think actually it's not the hand area, it's an area right next to it. It's called an intereffector, part of a scan network or somatocognitive action network that basically forms, let's say, the traffic lights. So you have the roads are there, the roads are not damaged. You still have all the roads that will carry the motor signal, but the problem is in the traffic light system, and there's a traffic jam because of this. And that's why you're not, Parkinson's disease patient is not moving, because of that traffic jam. And if you have an emergency in these patients, let's say, the fire alarm goes off, then a Parkinson's patient can just get up and run out of a building, even though, a couple of seconds earlier, that patient wasn't able to get out of a chair. So that's called paradoxical kinesia. And it's just because of that, because all of a sudden we've cleared the traffic, we've created another pathway for the traffic to go through, and the movement gets through. So that's what we can learn and understand from studying these brain networks. So you can see even our concept back then has been revised now with kind of this new information that we have.
Yeah. This part was fascinating for me, and actually just a few weeks ago in my program we led a lecture on this, and showing how for years we were always thinking the homunculus term, and now instead we know that the scan is there, and so way more about even the cognitive intentional part, the sophisticated control of movement, not just limbs and effector. And it's fascinating, the Neurosurgeon, or the proposal that came to really think, okay, maybe Parkinson is also a specific disease of the scan network. It's going to be fascinating to see where we're going with this new discoveries and way of thinking. A little bit of a difficult question now. What is the most fascinating or counterintuitive also thing that you will learn about the human brain through your work?
Ooh, that's so for me, fascinating. I think we're very rigid in our thinking, because we think that our perception is reality. We think that what we see around us is actual reality. whereas most of what we see is a model that the brain builds, based on incomplete information from what we can see and what we can hear. And the brain fills in the gap. So the brain plays this kind of it's a massive trick to make us feel that we are aware of our surroundings completely, but what we are seeing, I think, is we're seeing through a small slit in the veil the world around us. There's so much more to the world that we can't see or feel or hear. And I've always found that incredibly fascinating. Maybe not very surgical, but it is. But the other thing that I find fascinating is, as much as I like, studying Parkinson's disease, I find pain as a very kind of, primitive sensation, very hard to treat sometimes, and I'm really interested in figuring out how we can switch off. Where are those switches in the brain? Because at the end of the day, everything is in the mind. Everything is in our brain. We just need to find the right switches so we can turn that pain, and I don't mean, the pain that's useful. I mean chronic, agonizing, debilitating pain that, that robs people of their lives. And if we can find that switch that can just turn it off, that would be amazing. And I can then die a happy man, knowing that I've done something useful. And to the same extent, mental disorders, very complex mechanisms in the brain, it's something that kind of damages people and their families and their lives. So if we can better understand these conditions, I think we'll be able to affect real change.
I want to continue the conversation about pain because you anticipated me. So when somebody, very practically, when somebody come, say, to you and the major symptoms is pain, how do you approach this case? What do you think, maybe from a brain network perspective or a specific spot in the brain? And then how do you decide the treatment, whether it's more a surgical lesion in a specific area of the brain or it's maybe just a stimulation?
Yeah. Well, the main thing to do to understand what is causing the pain is to listen to the patient. And I mean, really listen to the patient. You can't, pain is a very, very subjective experience. I can't feel your pain. There's no way you can feel my pain. And you have to really listen to the patient, listen to these clues and what the patients say, whether that's what is the emotional aspect of the pain, or as we call the affective aspect of the pain. Is there what's the impact of that pain on the patient? How descriptive the patients are of that pain. Obviously, the pain type and character itself is important. Is the pain distractible? Does anything makes the pain better, or is the pain there all the time? All of these questions kind of help me understand the cause of the pain, and taking a proper history from the patient, doing a proper examination, and understanding what has the patient had to treat that pain from medications. What are the side effects from these medications? Is it worth the patient taking very high doses of morphine just to get rid of the pain, but they're actually not living their lives because they're dependent, and then once I get all of that, then I have to start thinking about in a systematic way. So think about the pain system and what treatments we have that can work for that specific type of pain. I see a lot of patients with trigeminal neuralgia and facial pain, and we have, to an extent, very effective treatments for these conditions. We also have experimental treatments that we try. Patients with cluster headache, the worst pain known to humans, also often called suicide pain because patients can't live with it. Cancer pain is another type of pain that we treat really well. But there are types of pain that are very difficult to treat. So neuropathic pain in patients following strokes. And it's something that I'm in the process of starting a project to try and map out, the circuit that affects patients with neuropathic pain. So it's a very satisfying and fulfilling field to be in, but it's also very, very difficult, and a lot of surgeons would just not get involved in managing pain just for that reason, because it can be quite draining, can be quite difficult. But I go back to what I said earlier. If we can crack that nut, I think it will be worthwhile with that effort.
Harith, I will anticipate this question now because, you are so inspirational. I mean, you have been a mentor for myself, and I was, reading all your studies and research. I had exam on your papers. What is your mission?
Oh, gosh, I haven't really stopped to think about that. I mean, I want to say, I really want to make the world a better place. I know that sounds like really cliche. Well, maybe I'll say it in a different way. I don't want people to suffer. So if I can alleviate suffering in any way and make people's lives better, then that will make me very, very happy. My late father taught me, it's very strange actually, because he wasn't kind of a soppy character, but love is the most important thing in life, and I really love people. Most of them, not all of them, but I do, and I love my patients, and I want them to. I don't want them to suffer. I just want, I want to make them better. I think it's, I mean, I'm not an angel. I obviously have, I want personal glory, and I want to be successful, and papers in Nature, and I want to show off all of that. So it's also all of that, obviously. But I think just being able to make a change and feel that I have done my bit, I think is very important to me.
We replicate more Harith Akram so that everybody can become
I
like
don't
this.
know, I might be completely delusional anyway, so whether that's useful or not, who knows?
Well, you are for sure, leaving a legacy because you're also such a big mentor and inspiration for so many young neurosurgeons and neuroscientists. So I think you are doing a very good job already. So yeah. I would like to come back to the point that you made at the beginning when you were a child, that you like to build and create things. What is Gilgamesh?
So, well, I'll tell you who is Gilgamesh first. So
Who is
Gilgamesh,
Gilgamesh? Yeah.
Gilgamesh was a Sumerian, well, say mythical figure, but he's the main, protagonist of his eponymous epic, the Epic of Gilgamesh, which is uh, the first epic ever written, I think, documented in human history. And he was probably the one of the king. I mean, he was in the epic. He's the king of Uruk, which is the oldest city in human history. Um, but in the epic, he is half human, half god, and he's a giant, and all of that. There might have been a real Gilgamesh that was embellished upon, but he was on a mission to go and find the basically the treatment for eternal life. To go and find a plant that will cure and give humans eternal life, because to save his friend Enkidu, who was dying. I love that story, and I love the history. Sorry, my printer is now printing randomly. So I'm sorry.
No
Just
worries.
printed something. Um, so when I started my PhD, one of the things that we wanted to do is um, wanted to process to that fits really well with one of your questions about translational science. So we were able to map out a human brain. It wasn't a new thing, and map out all the connections in the human brain. But that usually took a few days to do, because the computational power that's required to do that is huge. And if you wanted to use a supercomputer, you have to, you can't do that in a hospital. Hospitals don't have supercomputers. Not all hospitals, anyway. Very few, maybe. So I thought, if I'm going to do this PhD and I'm going to have over 100 patients participating, I need to be able to process these scans or brain connectivity in hours. I can't spend a couple of weeks per patient. I won't have enough time. So I had this idea that and I knew that GPU, so this is the graphic processing units, were being used to compute, so rather than the CPUs. But they were very expensive, and we needed to use, they were very specialized. And I thought, well, if I get gaming graphic cards, which were a lot more accessible and cheaper, I put four of them together and then try to write the code to get to get those to do the processing. That might work, but I had no idea that it will work. All I had this idea, and I went to Ludwigsrinzo, and I said to him, I have this idea for this computer that I want to build. And I said, are you going to build it yourself? And I said, yeah, because it doesn't exist. And he said, well, do you know that it's going to work? And I said, probably. And he said, well, how much is it going to cost? And I said, well, this much. And he said, okay, here's the money, go and do it. So I then contacted the UCL team responsible to get all the components, and within 5 minutes, um, the head of that department, Chris, just came to my office to talk to me, and he said, I have never done anything like this before, but it's very exciting. And he worked with me. We got all the components. It took months to get everything together, and then it took a couple of weeks. My office was just had components everywhere, and we were trying to get everything put together, and then put it together, switched it on, and it worked, and it was incredible. But then it took about 6 months to get it programmed. It took forever to get it to work. And believe it or not, still working. In fact, right now it's processing a human brain. That's 13 years later. The technology is now such commonplace that it's nothing special. GPU clusters are now everywhere. All software is written for them, is compatible to work with them. So it's nothing special now, but it was one of the earliest computers that we had. And after building it, UCL commissioned four others, four other similar computers, which was quite cool. And at the time, a friend of mine, Chen Wu, who is now a functional neurosurgeon at Jefferson's in the States, was also doing a fellowship in Queen Square. And he returned to the US and was appointed as an attending there. And he called me and he said, we need to build another one here. So he built one at Jefferson's and we called it Enkidu. It was Gilgamesh's friend in the Epic of Gilgamesh. So we have across the Atlantic, we have Enkidu, who is still working, and we have Gilgamesh here in London. Which
That's so beautiful, Harith. Like, when you hear, these stories, like I think that, I myself still, I would call myself still a student of yours, another, neurosurgeon like this. It's just so inspirational to say like, wow. It's like that is driving like really not only research, but, like really like the legacy behind. So that's fantastic. That's really beautiful to hear. So like for our audience, you see not only a neurosurgeon, an amazing human being, an amazing engineer, an amazing clinician, an amazing doctor. It's just so beautiful to have you here and like just, sharing so generally all this information. So again, thank you. There's another thing that you built. So how does this relates to Gilgamesh or not, which is a new MRI sequence called FAT1? Can you tell us what is it? What problems were you actually trying to solve? And what do all these tools allow you to do now that, let's say, wasn't possible before when we didn't have these tools?
Yes, that's one of the things that I'm really proud of, because when we started the human, the brain mapping work, one of the biggest problems that we had was to try to find a nucleus in the thalamus that's, very close to the middle of the brain, that is the hub that relays the tremor signal in the brain. So the tremor signal comes from abnormal synchronization between, in a very simplified way, between the back of the brain, the cerebellum, which controls coordination, and the effector region of the brain, the motor cortex, the hand area. And that signal gets relayed in the thalamus, in a part of the thalamus called the VIM, the ventrointermedial nucleus. The problem is we can't see it, and we can't see it on normal MRI scans. We can just about see it on 7 Tesla scans, so very high resolution scans that are not available in clinical practice in general. So what we were relying on is something called tractography, where we get these diffusion scans that will take an hour to get, and then we run an algorithm that will trace the water diffusion in the brain to try to see where it relays in the brain, in that part of the brain. And we managed to do that really well. So I actually published a paper in neuroimaging looking at thalamic connectivity-based segmentation and targeting, and that worked really well. But there were some issues, and the main issues are that these algorithms sometimes fail. Sometimes they overestimate the diffusion, the fibers. Sometimes they underestimate, and there are some caveats with them. And my idea was that if we're able to map out this nucleus in the brain using a diffusion scan, it means, the data is there, the information is there. We just need to find a way of transferring it, not on a tractography scan, but getting that information and putting it on a normal structural brain scan, like a T1 scan, which is what we use to see the anatomy without having all these tracts and without having, colorful tracts. So I did some playing with the sequences and ran some, mathematical filtering on the diffusion. And what I ended up doing is multiplying that signal that's been processed from the diffusion scan onto the T1 scan, but in a way that it's not distorted, because usually the diffusion scan is very distorted. And we managed to create this new type of imaging called FAT1 that shows you these nuclei in the thalamus without needing tractography. So all of a sudden we had this anatomical scan, which we use just like we normally use anatomical scans to target the subthalamic nucleus or the GPI, without tractography, without having to worry about all the problems with these algorithms. And that's what we've been using. I think I've looked the other day, and I think we've had about 150 patients who've had surgery using these scans, which is amazing. And that's and it's just made surgery so much safer. It made surgery very quick, and because when you can see your target, that's half the battle. In fact, that's probably about 90% of the battle won. The problem is when you can't see the target and you're feeling in the dark. And that's now it's part of our day-to-day practice. It's not research anymore. The challenge I had in the last few years was to make that as simple as possible for anyone to use. And that's actually been quite challenging. But we're nearly there. We're now testing our first toolbox that is completely surgeon friendly. That you would just install it and then you put your scans on it, and it will give you the new type of scans without needing to do any programming, without needing to learn any piece of code. So that's my mission now. It's nearly there, being tested. But we've published a couple of papers on FAT1 and been quite pleased with that. I mean, that's something that I'm really proud of.
I remember one of the first paper I had to read it. I was still also studying. I was like, it's like a little bit difficult, but then I kind of think it's it's not, when you had this big breakthrough, basically in neuroscience, like people like you, like brilliant minds, visionary, because you are a visionary. You see ahead of time how can we do and solve, and it's just sometimes challenging the way of thinking, the way of changing perspective. And so from here, my next question would be, how would you like to challenge the current field? Maybe you're specific in neurosurgery, maybe generally also Parkinson field, to look at a few things differently. What is missing? Maybe, then there's also needs for other tools, other technologies like this.
Yeah, I think that's really difficult. It's really difficult because dogma is very difficult to challenge. People are often set in their ways, especially surgeons. Surgeons are very conservative people. You learn how to do something. It's taught to you by your mentor and your mentor's mentor, and that's it. And that's how you do things. One of the biggest dogmas that we think, it's something that was instilled in me by Ludwig Zrinzo and Marwan Hariz, is that whatever intervention you do, it has to be, the patient has to be the center of that intervention. So, we're not experimenting on people. When someone comes to you for deep brain stimulation, then it's your duty to do the safest intervention, the most comfortable intervention for that patient, even though it might be interesting for me to do the operation with the patient awake. so I can do some testing and I can check what the effects are. Or I can get the BBC to come and film me doing that so that I can get on TV and show that my patient can now, play a musical instrument and they couldn't do before. Is that necessary? If it's um, if it's not necessary for the patient, then that's the wrong thing to do. And so one of the things that we as a unit, as a team championed was the use of, doing these operations asleep, and without stopping medications, without shaving any hair. These are all, used to be very radical ideas, right? Now a lot more, accepted. Without doing microelectrode recording and putting needles in the brain because that increases the risk. And that's something that was started before my time. It's not, I wasn't leading on this. But now it's becoming the standard. It's becoming more and more acceptable that, we are trying to make these operations as safe and as comfortable as possible for patients, because we want the patients to come. We don't want patients to be terrified. When they go online, they see surgery, patients awake, for 8 hours in the OR and they're being tested. You have to be very brave to go and get something done like that. Or you have to have absolutely no other choice. But if we can make it simple and easy and safe for people to do, then we can help more patients. And I'm not against doing, science, obviously, but you have to be clear. This is something that we're doing. We're doing recording, keeping patients awake, and we do that because we have an important science question that we're trying to answer. But I wouldn't do that for every patient because I want to get the data, and So I think that's something that we, as a community, we need to be aware of all the time.
I hear a beautiful message here for all our listeners to have hope, to have certainty, and be fully rely on your clinicians and your neurosurgeons. But is there maybe, when people come to you, do you see any fear or doubts that they have? And so how do you try to navigate those conversations to make them more just at ease?
Yeah. Well, first of all, so I always ask patients if they are nervous, and almost always they say yes. And I always say, well, I'd be really worried if you weren't. And I think it's very important to acknowledge that this is a really nerve-wracking experience. So I'd never dismiss how a patient feels about having brain surgery. And this is a huge thing. And even though I do it every day, so for me it's routine, for a patient it's incredibly daunting. I've had the pleasure of being a patient myself, so I know what it's like to not have, to not be in control. I mean, not being in control of a situation where you're the object of the intervention is terrifying. So it's my job to reassure patients, not by dismissing the seriousness of what's happening, but by if I can giving them confidence in me and my team, and promising them that I'm going to do everything I can, my best to look after them, but also without lying to them, without telling them that I'm infallible. I'm a human being and I can make mistakes, and sometimes I can do everything right and things don't go well. And as long as I'm open and sincere about this with patients, and give the patients the time and the chance to appreciate the risks, but know that I'm prepared is important.
And do you think there's sometimes then a mismatch between what patient hopes surgery will do for them and what it can realistically achieve sometimes?
Yeah, and managing those expectations is crucial. And which is why I think we need to focus on what is the functional outcome that we're looking for here. When I operate on a patient who has tremor, my outcome is not to stop the tremor. No, my outcome is for them to, what I want is for them to then go out and have dinner at a restaurant when they couldn't do before. Is to be independent and they can, dress and undress and they don't have the social anxiety and the functional disability that they have. So as long as we're realistic about that, then everyone will be happy. As I said, I'm not infallible, and I think it's also good for patients to appreciate that a 1% risk of something going wrong is a 1% risk, and if I have 100 patients a year, then that 1% will get an infection. That's my. I can't. It's a lot of it is also to do with how surgeons communicate and physicians communicate those possibilities to patients. So I'm not paternalistic in my approach. I think, well, age teaches you.
I cannot hear you anymore.
Oh, you can't hear me?
You're back.
Yes. So
yeah,
I think
you're back. You were.
Yeah. So experience teaches you humility. And, I have a lot of that.
I see. Well, that's for me, is there, God forbid, if something happens, I want you to be my surgeon. Like to that level, I think we are really here, making clear for people like the type of communication that the patient should be having with the neurosurgeon or like even the neurologist. So it's really, really important to, as you said, like manage those expectations, say that we sometimes, are not always correct, but that it's our duty to do our best. Let's say, from your perspective as an optimist, where do you see the greatest opportunities or maybe some exciting venues for the future?
Well, I mean, I see the greatest opportunity comes from trespassing between different specialists and different fields, and cross-fertilization between engineering, computer science, medicine, and technologists, because we have the tools. We actually have quite a lot of tools. The problem is we all work in silos, and we are not we're not working together. So I was involved in a trial recently where I had 4 engineers in the operating theatre, and it was amazing because there was a couple of engineers operating a robot, an engineer supervising the surgical process, another engineer kind of looking and supervising the implant. It's a game changer. So I think where I can see things happening in future is when you get different specialists working together, but with the same understanding and the same goal. AI is going to be a massive game changer, and we're seeing it already, but I think we're just seeing the tip of the iceberg, really. I think this is going to explode in terms of improving the quality of imaging, improving the quality of data processing, pattern recognition in clinical practice, programming, DBS electrodes, harvesting biomarkers. So it's yeah, I'm very excited to see what's going to happen in the future. That's
If you were to have a superpower, would this be something and then you would like to change, like to make sure that we have more of this cross-modal communication and like really have like by default, not just the clinic with just doctor, but like technician and data scientists and engineers and
yes, of course. But if I really, if you tell me if I can have a superpower, then it will have to be time travel. So,
okay.
yeah, so I'd love to
Nice.
travel. Not even if I'm not making any change, I just want to go and see in future what human beings are going to do. I mean, isn't that exciting? And I want to go back to the
I
past as
can
well.
relate to that actually.
Go to the past and see what life was like when Gilgamesh was around, and yeah,
I
that would be
myself sometimes was thinking, who are the specific person from the past that I would like to meet and ask them like how they are so visionary, like a Leonardo da Vinci, for example. So, which by the way, I don't want to seem like or sounds too extreme, but all your expertises and what you have been, talking and your way of looking at things in such an open way, like definitely not in silos, like makes me think back even like a little bit of Leonardo. So that's
I don't know.
that's really beautiful.
We both have a bit of autism. That's why.
For the benefits of everybody. So
Yeah.
that's worth it. Tell me, so you indeed are a professor, a mentor, a big inspiration for like young students as I was, and I'm still, and so what is your idea or mission in forming this young generation? And when you think back of, well, you are again like really leaving a legacy behind you.
Well, I think the first thing is to say, don't take yourself too seriously. That's very important. Um, and really, you have to do something that you find fun. There's no point in doing something that you don't think it's fun. And focus on the end of the day on humans. How is this going to help, fellow human beings? If, whatever, scientific endeavor we are, we're embarking upon, it's meaningless if it's not going to translate into improving, the lives of humans. I mean that that does include, science research for the sake of knowledge that is going to enrich our world. We want to understand how things work. That is, that also helps humanity and helps us conserve the planet. But yes, my advice is if you are doing medical science research, whatever you do, you have to put human beings at the center of it. And find a good mentor.
That's, yeah. I have had mentors and coaches all my life, so that's definitely one of the most important, like, lighthouses, I would say, for the journey and the path. And how important would you say it's the relationship on one side with the mentor and on the other side with the patient to be very human? And what does it mean for you to have a human relationship with, say, these profiles?
It's it's not that easy, especially in medicine, because well, for different reasons. One of them, most of the time doctors don't have time, and you don't have time to create a human connection with a patient. Not because the doctors are don't care, or these doctors are horrible, but they're just under so much pressure that they don't have time to create that connection. And the other problem is being defensive medicine, because and that's something that is becoming more and more a problem in the UK, at least. I mean, I know it's the case in America, where doctors, or a lot of doctors will are scared of making a mistake, or being sued, or being punished, or scared of complaints, that they stop seeing patients as the reason why they're there, and they start to see them as problems, and that can degrade that relationship between doctors and patients. So I think that's very important if you wanted to be to have that human connection with patients. And I think one of the other main things that you need to do to have that connection, have that confidence, is just to be completely open and honest. Because the minute patients realize that you're not being honest with them, or you're not telling them the whole truth, and they just won't trust you, and that you can't have a real human connection, without that trust.
I heard, terrible stories. Canada, US are sometimes like at the front line of some really horrendous stories. I hope that many people will listen to this podcast so that actually hear, okay, what does a virtuous relationship with the clinician and a doctor actually look like? So thank you for sharing, of course, all this. Slightly go now towards the end of this conversation, but not in the usual way. Okay, so we have a sort of tradition on this podcast, and I would like to call it a moment of further connection and desire to make it a little bit also maybe playful or enjoyable. So 2 things. First, we have our 90 seconds rapid fire challenge. And basically, I will just give you 3 questions, okay? Very fast, direct, and clear. They're gonna be easy, okay? I don't want to put you on a spotlight. And this, sorry?
What's my favorite color?
Okay, yeah, almost. I can ask that if you want, but more related to PD in this case. And the second will be that I will actually ask you to leave some things behind for the next guest. So somebody who, you don't know, of course, who this guest will be, and that's going to be a surprise. So whatever you think a relevant question might be for somebody, maybe a colleague of yours, maybe somebody in the field of PD. So something to push the momentum forward and go further with the conversation, okay? Ready? So the first thing is, what is the most critical gap that you see in current Parkinson field?
Subtyping, I think. Diagnosis and subtyping of Parkinson's disease.
If there is one thing, a concept, a misunderstanding, something that you would like to change about Parkinson's, what would this be?
I think we need to stop seeing Parkinson's as a movement disorder. It obviously is a movement disorder, but it's much more than that. I think it's if we just change our perception of Parkinson's as a whole brain disorder and a whole body disorder, then I think we can focus our treatments better, potentially.
Third one, something that is, say, broadly believed, but it is actually a misconception. And on the other hand, something that is not always understood, but it is actually critical in how we understand research or PD.
Gosh, okay, that's not a quick question. You put me on this spot. What can I? I'm gonna have to think about that.
It's okay. It's okay. Take your time. Okay. Then tell me in the meantime, what would be this question that you would have for our next guest?
It all depends on who the next guest is, because it has to be.
Try to be a visionary as you are.
It has to be appropriate. And is it going to have to be Parkinson's related? Yeah. So I think I think the next question will be, how can we've had, so I think the question is, we've had 15 years of developing the current, say, is it more, not more than 15 years, 25 years of developing the current electrodes and neurostimulators. But the reality is, this hasn't really changed the outcomes for patients that much. We still get about 50% improvement in motor scores in UPDRS3, and that's been amazing, not to be taken lightly. But actually, all this investment and all this work hasn't really led to a huge improvement. What do we need to do next to get more than that 50% improvement in outcomes with surgery? I'm basically talking about, deep brain stimulation for Parkinson's disease. How do we get more than that? What do we need to do? That's a very difficult
I will have to, yeah, it's a question. Yeah, I think I might then act here, as the, like, really,
Oh, I'm sorry, I
like,
apologize.
pinpoint the question. No, it's beautiful. So, like, I might then decide, like, who I think could actually answer this question. So I have many people coming. We are, of course, going to the World Parkinson Congress soon, and I will meet so also other beautiful, brilliant minds. So I'm happy to have your question on the podcast. So definitely we'll keep. Yeah, we'll definitely keep the momentum.
Tell me the answer.
I absolutely will. We will also put the script all down, but I will make sure to email you back and text you back for sure. But Harith, we are going to close now here. Okay, thank you so much for your time. For our listener, we just like to take a moment before we officially close, because I think that this conversation really deserves it. What strikes me the most about everything that you shared with us today is that the most sophisticated science and the most human instinct are not at all opposite. Even once more, a further inspiration for everybody and just for me. A surgeon who builds supercomputers and fantastic technologies to map also individual brain networks, but also a surgeon who actually cares for people, listen to them. They call them by name, basically. You're a researcher who publishes in these most prestigious journals, but you're also somebody who sits with a newly diagnosed person, tries to make them more, sure, give them hope. And you are, again, leaving a legacy that it's something that I think you should be already very proud of, because I think that you have good missions, but you are already accomplishing it. So thank you so much for your time from the bottom of my heart, for the science, the clarity, the humanity of being here. And I'm pretty sure that everybody will learn a lot from you.
Thank you very much, Gaia. Thank you. I've really enjoyed this.
Thank you so much.